Okay, class, this is our review for our endocrine presentations. So hopefully this works well. I'm sorry we can't interact, but this is better than nothing. And just before I get started, I'm not going to apologize for the wind noises because my mental health just requires that I be outside on a day like today. And I hope the rest of you are enjoying this amazing day also. Okay, so let's get started. First of all, we know that we have endocrine glands that will secrete hormones, and they secrete them directly into the bloodstream to either increase or decrease different physiological responses in our body. We're basically looking to, for example, maybe grow a few inches, or maybe the secondary sexual characteristics begin to develop, etc. So for whatever reason, those endocrine glands are going to create those physiological processes. They also play a vital role in regulating the homeostatic processes of metabolism, growth, fluid, electrolyte balances, reproductive processes, and our sleep and awake cycles. The different glands we look at, we have the pituitary gland, the hypothalamus, the thyroid gland, which is located in the lower neck anterior to the trachea, parathyroid glands, the thymus gland, the pineal gland, the adrenal glands, the pancreas, and the ovaries and the testes. However, we won't talk about all of these, just some of the more important ones. There are additional hormone releasing organs, and those are going to be those organs in our body that are not considered to be endocrine glands. However, they are going to secrete hormones. For example, we have the atria of the heart. If we develop a process called congestive heart failure, it causes that atrial tissues to begin to expand and dilate. As they begin to expand, then they release the BNP hormone. And we'll talk more about that when we get into the cardiac section. The kidneys, we'll be talking throughout this semester and next semester about the erythropoietin hormone that's secreted by the kidneys. And this hormone actually causes production of red blood cells, or stimulates that production. Our skin also secretes hormones. The placenta and some of the gastrointestinal structures. When we begin our assessment of the endocrine system, it's really important to help diagnose some endocrine disorders. We do understand that some of our endocrine disorders can have very vague symptoms, so we as nurses need to be very cognizant and very aware of different things that can indicate a disorder in the system. We look at possible genetic possibilities because they can also be passed on from person to person. So it's important to obtain the family history. The diet and drug history that a client imbibes in or undergoes is also important. It's really important for us to determine if the client has an allergy to iodine or shellfish, because iodine is used in many contrast dyes, especially when we're looking at the thyroid or treating the thyroid. And we find iodine is in a lot of the shellfish. So if they're allergic to shellfish, then they very likely have an allergy to iodine also. And again, current symptoms can be very vague, and they can also be very dramatic. So really important to get a good history of the client's current problems and different symptoms they're experiencing. When we move on to the physical examination, we need to look at the vital signs, their height, their weight, their general appearance, and that would include body structures such as their skin, their nails, their eyes, their facial expression and features, and extremities, looking for edema and tremors. We assess for motor function and sensation. We're going to assess their mental and emotional status. And then we gently palpate that thyroid gland, making sure it's a gentle palpation, because a forceful palpation of the thyroid can actually cause an over-secretion of the thyroid hormone. And if they have thyroid problems, that can lead to what we call a thyroid storm or thyrotoxic crises. Now we'll talk about some disorders, and we'll start off with the pituitary disorders. Now we're not going to talk about all of them that are on this slide, but we'll talk about some of them. First of all, we have the process called gigantism, and this is where we have an oversecretion of the growth hormone. The other disease process where we have an overgrowth of the growth hormone, or oversecretion of the growth hormone, is called acromegaly. Now these are similar, but yet they're very different. With gigantism, the two main differences is that it's going to cause the bones to grow longer. So these clients will grow very, very tall. And this will happen before a client reaches the age of puberty. Now with acromegaly, this happens during adulthood. And it doesn't cause the bones to grow longer. It causes them to grow wider, so they get broader. There are several different medications that can be used to treat acromegaly. They can prevent the disease from getting any worse, but it will not reverse the symptoms of the disease. Something else we can do is radiation or hormone therapy or other drug therapy. And we can also do surgery, where we actually go in and remove the pituitary gland. The pituitary is located in the brain, and it's very near the nasal passages. So the procedure to remove the pituitary gland often goes through the nasal passages. We call this procedure a hypophysectomy. So post-operatively, it's very important to include monitoring for increased intracranial pressure. So anything that's going to cause strain on the abdomen can increase the pressure in the skull, such as even straining to have a bowel movement or sneezing or coughing. So we want to discourage this as much as possible. And we also need to monitor the drainage from the nasal packing post-operatively. You know, we would expect to see maybe a little bit of blood, which would not be abnormal, but we don't want to see that clear yellow drainage that could indicate possibility of cerebrospinal fluid that is leaking out of the surgical site. And to test and see if it is cerebrospinal fluid, we can put a drop of it on a clean white gauze. It will develop a halo around the drainage, and that's how we determine if it's CSF fluid. An insufficient secretion of that growth hormone during childhood will result in dwarfism. Another disorder with the pituitary gland is called diabetes insipidus, and this is where the body will excrete extremely large amounts of urine, and it's caused by too little of the antidiuretic hormone, or ADH. It can also be caused by an inability to respond to ADH or head trauma. And that would include a brain tumor or, for example, maybe a hypophysectomy. These clients can have up to 20 liters of urine in a 24-hour period. So they have polyuria, definitely have weight loss, constant thirst, weakness, and dehydration. And these are going to be extreme symptoms of dehydration. So, of course, they're going to start off with the tachycardia, or fast heart rate, and tachypnea, the fast respiratory rate, to try and make up for the lack of volume that's circulating in the body. But they're also going to have significant hypotension because they just don't have the volume. They're peeing it out faster than they can take it in. So we're going to treat it by giving fluids and try and determine the cause and correct the cause if at all possible. They're also going to develop hypernatremia. And I know this sounds a little bit counterintuitive because, or no, it does not sound counterintuitive, I'm sorry. They're peeing out massive amounts, they're dehydrated, so everything is concentrated. So very important to know, but they can cause hyperkalemia, which that one is counterintuitive. So the syndrome of inappropriate antidiuretic hormone, also known as SIADH, is going to be the reabsorption of the body's water instead of excreting it. So opposite of diabetes insipidus, where we're getting rid of too much fluid, with SIADH, we're not getting rid of fluid. We're holding on to it. And this can be caused by lung and brain tumors, CNS disorders, head trauma, and that would include strokes and some drugs. These clients are retaining water. They have hyponatremia, headaches, muscle cramps, anorexia, and changes in level of consciousness. So the thyroid disorders. The thyroid gland regulates the body's metabolism. So we either can have a fast metabolism or a slow metabolism. If someone has a thyroid disorder, that treatment can be long-term, and it can also take several weeks to be effective following the initiation. So as nurses, if we're treating someone with a thyroid disorder, we need to include in our education that it can take several weeks before this therapy is actually, they're noticing a difference in their symptoms. So let's look at hyperthyroidism. We also call this Graves' disease. We have a hypersecretion of the thyroid hormone. And this can be from autoimmune disorders or from genetic traits. These clients have an increased metabolic rate. They're very restless, they're agitated, they have hand tremors, they can have diarrhea because things are moving through the gut so fast. They have an increased appetite because they're burning so many calories. But they have weight loss because their metabolism is just so fast that the fats and calories don't have a chance to really attach themselves in the body. They have a process called Exothalamus, which if you look at your slide is a picture of this lady with the bulging eyes. also known as thyroid eye disorder or thyroid eye disease. They may have neck swelling, and that would be due to a goiter, and tachycardia, hypertension, elevated respiratory rate or tachypnea, and warm, moist skin, because they're sweating, everything is just hyped up, it's ramped up, everything is really speedy. We can diagnose it by looking at their T3 and T4. They will be elevated, and their TSH will be decreased. We can also do a thyroid scan or an ultrasonography. Remember, forceful palpation of that thyroid can release high levels of the thyroid hormone. So it's really important to monitor their vital signs. Again, we expect them to be elevated. They may even have an elevated temperature. We need to monitor for signs of hypocalcemia. We need to encourage rest, and they need to eat a high-calorie diet. These clients may require diets that are 4,000 calories and above just to keep up with their nutritional needs. A thyrotoxic crisis, also known as a thyroid storm or thyrotoxicosis, is an abrupt, life-threatening form of hyperthyroidism, and it's triggered by stress, infection, diabetic ketoacidosis, trauma, toxemia with pregnancy, or palpation of a hyperactive thyroid. These clients will have a really high temperature, a very rapid pulse, dyspnea, cardiac dysrhythmias, delirium, and vomiting. We have to treat them immediately, and usually we'll use antithyroid drugs or IV sodium iodide. Now, hypothyroidism is going to be the failure of the thyroid glands to secrete sufficient hormones. So these clients have a slowing of the metabolic rate. A severe form of hypothyroidism is going to be myxedema, and that can lead to a myxedema crisis or coma. So clients with hypothyroidism are very lethargic. They have weight gain, dry skin, menstrual disorders, an enlarged heart, atherosclerosis, anemia, and cool, dry skin. We treat it by replacing the thyroid hormone. Again, we need to monitor and educate the client that this thyroid replacement can cause the opposite effect. So we need to educate them on what hyperthyroid symptoms are. As with a lot of the things that we're treating, we need to make sure that we're not going too far the opposite direction. So in this case, going from hypothyroidism to hyperthyroidism. Talking about the goiters. The goiters are going to be caused by iodine deficiency. Usually, these people are going to be treated by encouraging foods that are high in iodine, administration of potassium iodide, or a thyroidectomy. Parathyroid disorders. The parathyroid gland maintains serum calcium and phosphorus levels. So when we have hyperparathyroidism, this is an excess of the parathormone. Now the parathyroid gland is located behind the thyroid gland. So if we do a thyroidectomy, sometimes that parathyroid might also be removed. So we need to be monitoring clients for deficiencies in the parathyroid. So once again, looking at the hyperparathyroidism, it can be primary or secondary. Primary can be caused from an adenoma, increased secretions of that parathormone. And when we have increased secretions of the parathormone, it's going to be removing calcium from the bone and putting it into the bloodstream. Excuse me. So hyperparathyroidism is talking about the level of the parathyroid hormone in the bloodstream. And when we have that, once again, it's taking calcium out of the bone and it's putting it into the bloodstream. It can also cause bone demineralization and kidney stones. When we have high levels of calcium in our blood, remember that also is going to be going through the kidneys, and it increases that formation of kidney stones. Secondary hyperthyroidism is caused from increased secretions in response to hypocalcemia. So if we have hypocalcemia, it causes an increased secretion of PTH. These clients are going to be very fatigued. They're going to have hypotonic muscles, skeletal tenderness and pain, and cardiac dysrhythmias. So on the flip side, with hypoparathyroidism, we have a deficiency that results in hypocalcemia. So we don't have enough the parathormone being secreted, so we are not getting that calcium out of the bones. So the levels in our bloodstream of calcium are going to be low. This can also be caused not only from the deficiency of the parathormone, but also from trauma to the glands and just overall hypocalcemia. These clients are going to have neuromuscular hyperexcitability, tetany, and if you recall, that's going to be just a constant muscular spasm, the positive cough sticks, and Trousseau's sign. Laryngeal spasms that can also result in dyspnea. We need to, as nurses, monitor for signs of tetany and muscle spasms. If we are replacing calcium with IV calcium salts, very important to monitor the IV site. And we need to assist with ADLs and decrease stimulation. Now let's go back up to hyperparathyroidism. Remember, when we are pulling too much calcium out of the bone and it's going into the bloodstream, it's causing those bones to get weak. So the risk of pathologic fractures is significantly increased. And now we move on to the adrenal glands. The adrenal glands are basically going to secrete our steroids. We have the mineralocorticoids, the glucocorticoids, and the gonadocorticoids. These are all known as corticosteroids. And then they also secrete the catecholamines. And the two catecholamines that we really discuss are epinephrine and norepinephrine. So adrenal insufficiency is an inadequate production of corticosteroids. We're not producing enough, and we have to have steroids to be able to survive. This results in a disease process called Addison's disease. We have primary and we have Addison's disease. This is basically destruction of the adrenal cortex, but it can also be an autoimmune disorder that results in hypoglycemia. Secondary would be resulting from surgical removal of the adrenal glands, hemorrhagic infarction, hypopituitarism, medications. Basically, they don't experience enough symptoms because of steroid replacements. So these clients, before treatment, suffer from hypoglycemia, dark pigmentation, personality changes, anorexia, vascular collapse, and gastrointestinal symptoms. They are going to be treated with a daily, lifelong corticosteroid replacement therapy. So they're going to be on steroids basically for the rest of their life. Excuse me. We have to teach these clients that they cannot omit any of their dosages. They cannot change their dosage. They cannot stop their medication because it can basically kill them, sends them into the adrenal crises, which is a life-threatening emergency. They need to avoid infection or fatigue, and they should always wear a medic alert bracelet. Their diet will be high calorie, high sodium, high protein, low potassium, moderate carbohydrate with frequent meals and snacks. So that adrenal crisis, once again, is life-threatening. It can be caused by abnormal stress levels, trauma, salt deprivation, or sudden cessation of corticosteroid therapy. These clients experience anorexia, vomiting, diarrhea, abdominal pain, hypotension, and fever. We diagnose them by their gastrointestinal symptoms, their profound weakness, a headache, increased hypotension, restlessness, and fever. We treat it with corticosteroids, glucose, and/or antibiotics. So it's very important for nurses to be familiar with symptoms of adrenal crises, and we need to monitor these clients for that. We do this by monitoring their vital signs. And we also need to educate the client on adherence to the medication regimen. Then we talk about Theochromocytoma, which is a tumor of the adrenal medulla, and it causes it to have hyperfunction. So we have a tumor that's benign that causes an excessive catecholamine secretion. And again, that's epinephrine and norepinephrine. Excuse me. These clients are going to have an elevated blood pressure, tremoring, hyperglycemia, polyuria, which means an excessive amount of urine, vertigo, headache, nausea, and vomiting. We treat it by doing an adrenalectomy, and we can do just one. We don't have to do both of them, and drug therapy. Cushing's disease would be an excessive secretion of the adrenal hormones. So basically we have an excessive adrenocortisol, the ACTH hormone can be caused by tumors, or it can be caused by prolonged corticosteroid administration. So in other words, people that are on daily steroid therapy for whatever reason can develop Cushing's syndrome. These clients will develop the Cushingoid symptoms. This will include muscle wasting, so their arms and their legs are very thin. They have symptoms of diabetes mellitus because they're going to have an elevated blood sugar caused by the steroid itself. They're going to develop what we call a moon face. So it looks like their face just gets very puffy. It's not edematous. It's just very puffy. I don't know how else to describe it. They will develop what we call the buffalo hump. And if you look at your slide, this lady has that buffalo hump. It's kind of a fat pad located between the scapula. They have an increased susceptibility to wounds. Again, they're developing these diabetes symptoms and the symptoms of the administration of steroids. So their skin gets very thin. Excuse me. They don't heal very well. They have that slowed wound healing. They can also have easy bruising, and the women can develop some masculine features. So we teach these clients to never abruptly stop their steroid therapy because of the increased risk of the adrenal crises. And then hyperaldosteronism is the excessive secretion of aldosterone. Excuse me. It can be caused from a benign adenoma, a malignant tumor, or some unknown cause. These clients have muscle weakness, fatigue, cardiac dysrhythmias, headache, increased urine output, and hypertension. Once again, we treat it by removing the adrenal gland, and hopefully that will take care of that issue. And diabetes mellitus. This is that chronic metabolic disorder of the pancreas, and it affects carbohydrate, fat, and protein metabolism. We have two main types of diabetes, type 1, and this used to be called juvenile diabetes or insulin-dependent diabetes mellitus, but now we just refer to it as type 1, and it's caused by a lack of insulin production. In other words, they produce absolutely no insulin. It usually will occur in people that are younger than 20 years, but it has been known to occur in adults that are older than that. And then type 2 diabetes used to be called the non-insulin dependent diabetes mellitus. It's caused by insulin resistance. These clients are able to produce some insulin, but for some reason their body is resistant to that insulin. They may or may not require insulin injections. It is most commonly found in 45 to 65-year-old clients, but it's now being diagnosed in obese children. Prediabetes mellitus can lead to type 2 diabetes, heart disease, and stroke. Risk factors include being overweight or obese. Risk factors for type 2 diabetes also include gestational diabetes. In other words, the woman is showing signs of diabetes during her pregnancy. She may even have to take insulin during the pregnancy. But once the pregnancy has terminated, whether through delivery or whatever, then the diabetes goes away. Diagnosis would be made by one or more abnormal blood tests, and this would include the hemoglobin A1C, and that needs to be 5.7% or to 6.4%, a fasting blood glucose of 100 to 125, or an oral glucose tolerance test with a blood sugar of 140 to 199. Prediabetes can be delayed and even avoided with weight loss and increased physical activity. Hyperglycemia is an elevated blood glucose level, and this can be associated with pancreatitis, excessive adrenal cortical hormone secretion or administration, or some medications or treatments. It may require the use of insulin, but may not indicate the presence of diabetes mellitus. Basically, what happens with insulin? Insulin function includes carrying glucose into the body's cells. So without insulin, that glucose cannot get into the cells. It can also promote the liver's storage of glucose as glycogen, and it inhibits the breakdown of glycogen into glucose. So basically, if we don't have insulin, our body is unable to get energy to the cells, any of the cells. So with type 1 diabetes, what is happening is the islet cells in the pancreas are no longer producing insulin, causing that elevated blood glucose. So since we don't have that insulin and we can't get the glucose into the cells for energy, it causes the body to begin to break down fats and proteins for energy. So this can cause an accumulation of ketones, which is a byproduct of fat breakdown, and that will lead to metabolic acidosis, or also known as diabetic ketoacidosis. The body is going to attempt to self-correct ketoacidosis by its respirations, and we call this Kussmaul's respirations. It's fast, deep, and labored breathing, and what our body is trying to do is blow off excessive acid. And if we do have too many ketones, because we're breaking down too much fat for energy, our body is then going to, or our breath will then have what we call that fruity odor to it. And if you've ever chewed juicy fruit or smelled juicy fruit gum, that's exactly what the ketones are going to smell like. Diabetes type 1 is considered to be an autoimmune disorder, but it's also been known to be caused by a virus. Studies and trials are being conducted that can hopefully improve the treatment or even cure diabetes in the near future. At least, again, that's the hope. Type 2 diabetes is considered to be more of an inherited disease. Risk factors, once again, include that intra-abdominal obesity. So a lot of fat is put on in the abdomen itself, not necessarily elsewhere in the body. A sedentary lifestyle, and gestational diabetes. Once again, in type 2 diabetes, the insulin is being produced, but the body is no longer able to utilize insulin effectively, or they don't produce enough insulin. When we have a high glucose level in the serum or the blood, it's going to pull fluid into the vascular system. So it pulls it from the cells, from the body, into the bloodstream. And that will cause polyuria, or a lot of urine. And because so much urine is lost, the client will then begin to experience increased thirst, also known as polydipsia. Due to the body not using glucose as the fuel source, the client is frequently hungry, and we call this polyphagia. So the three classic symptoms of diabetes are polyuria, polydipsia, and polyphagia, in addition to weight loss, weakness, thirst, fatigue, blurred vision, and dehydration. These clients are at an increased risk for infection because glucose supports bacterial growth. With type 1 diabetes, there's going to be an abrupt onset. With type 2, we have a gradual onset. When we do tests, we're going to find glucose and or ketones in the urine. Our blood sugar tests, whether they're random, fasting, postprandial, which would be 2 hours after a high-carb meal, oral glucose tolerance test, the glycosylated hemoglobin, also known as the hemoglobin A1C, are all going to be elevated. The hemoglobin A1C is going to reveal glucose levels for the past 3 months. So this is kind of the lie detector test for diabetics. The doctor asks them how they're doing on their diet, how their blood sugars have been. Oh, they've been good. I've been following my diet. Blood sugars have been in the limits that you prescribed, and we do the glycosylated hemoglobin, also known as the hemoglobin A1C, and it's elevated. And it's like, okay, sure you were. This test has told me that your average blood sugar has been such and such for the last 3 months. So how do we treat diabetes? Well, it's going to depend on the type of diabetes, of course. We do know that tight blood glucose control will help prevent complications. It's not going to prevent all complications, but it will help decrease the complications and decrease the severity. Excuse me. The major component of treatment is going to be diet and weight loss. For type 2 diabetes, diet might just be enough to control it. It should include 3 meals and 3 snacks to keep the energy levels consistent. Increased fiber should also be included because it can not only help with bowel function, but it can also decrease blood glucose, decrease cholesterol, which diabetics are going to have an increased risk for arteriosclerosis, and it can also decrease the need for exogenous insulin. Exogenous insulin means insulin that we give to somebody. It's coming from outside of the body. Endogenous insulin is the insulin that we produce within our own body. The next type of treatment will include exercise, and exercise can reduce the need for insulin because it enables the muscle to take glucose in without insulin. It also improves our blood circulation and decreases it can, because it is burning that glucose in the muscles, can increase our risk for hypoglycemia. So clients that are diabetic need to be encouraged to do physical exercise. However, depending on the amount of exercise they do, they really need to be monitoring their glucose levels because they can become hypoglycemic. And insulin. All clients that have type 1 diabetes will use insulin. It is important for nurses to be familiar with the type of insulins, their onsets, the peak, and duration, and we'll talk about that here in just a little bit. When we're giving insulin, we need to alternate the areas of injections to avoid what we call lipoatrophy, which is a breakdown of subcutaneous tissue, or lipohypertrophy, which is a buildup of subcutaneous tissue. And then with some of the type 2 diabetics, they will also use insulin, and they can also use the oral anti-diabetic agents. Diabetic foot care is very important in the diabetic because of the potential of diabetic neuropathy, where they have the paresthesias in the feet and the lower extremities, possibly even in the hands, where they may have increased pain, but a lot of these clients just lose all sensation. So they can step on something, they can bump a toe, they can develop a wound on their foot and not even be aware of it. So these clients need to keep their feet clean and dry. They need to avoid keeping their feet too moisturized. They should wear appropriate shoes, and the diabetic shoes are designed specifically to prevent rubbing on the feet and creating wounds. When they're up walking around, they should always wear shoes. Again, because of the risk of injury and not being aware that they've done it. They need to trim their toenails straight across and don't cut them too short. Again, this can cause injury to the tissues, and they are not aware of it. They should always check their shoes before putting them on, because we know how things get knocked off of a table or a dresser, etc., and fall into a shoe. Or if there's young children around, they like to play hide and seek with toys, etc., or maybe even bugs crawl into a shoe, and they can create injury in the diabetic foot. So always check the shoes. They should not wear constrictive socks or clothing. They need to promote their circulation. And they should be taught to examine their feet daily using a mirror. Bariatric surgery might be an option for weight loss with some type 2 diabetics. And we can also consider pancreas or islet cell transplant that would potentially allow for insulin independence. This is only possible for the type 1 diabetics, however. So nursing management, we have to teach and reinforce diabetes care to include the disease process, their diet, exercise, medication regimen, administration, monitoring their glucose, inspecting their feet, getting routine appointments with their provider, and routine eye examinations. Diabetic ketoacidosis is a type of metabolic acidosis caused by an accumulation of ketones, usually due to insulin deficiency or an inability to use that insulin. We often see it in clients that have hard to control diabetes. Excuse me. They're non-compliant or non-adherent with their treatment, or in cases of infection. Some clients, they don't even know they have diabetes until they're admitted to the hospital with a diagnosis of DKA. And it's like, surprise. These clients are going to be very weak, thirsty, anorexic, once again meaning a loss of an appetite, have vomiting, drowsiness, abdominal pain, those Kussmaul's respirations, remember those deep, rapid respirations, a low blood pressure with a weak, rapid pulse. The treatment will depend on the severity of the DKA. The main goal in the treatment is to reduce the elevated blood glucose, and we do this through IV insulin to correct the fluid and electrolyte imbalances. So we're going to administer massive amounts of fluid, and we're going to replace potassium. These clients are going to have potassium imbalances. Hypoglycemia is a low blood glucose level. Now, it can be an adverse reaction of diabetic medications, not eating or taking diabetic medications, not eating sufficient calories with diabetic medications, or exercising more than usual, or alcohol. However, it can be a disease process in and of itself, where they've never been diagnosed with diabetes mellitus, they just have hypoglycemia. These clients will have nausea, drowsiness, hunger, malaise, excessive perspiration, confusion, slurred speech, coordination difficulty, and personality or behavior changes. A lot of times they even act like they're drunk. Having a blood sugar that is too low can be more hazardous to the client's overall health status and potential recovery than having a blood sugar that is too high. So we're going to treat hypoglycemia by administering 15 to 20 grams of a simple carbohydrate as soon as possible. Excuse me. We can administer a substance called Glucagon. We can give an IV administration of 50% glucose. We can, once we get that hypoglycemia corrected enough that the client is able to eat or drink, then we want to start giving them some complex carbohydrates. So initially, we're going to give them simple sugars. We want to get their blood sugar up as quickly as possible. But those simple sugars will drive the blood sugar up quickly, but it doesn't maintain it for very long. So as soon as they're able to eat or drink, then we need to give them some of the complex carbohydrates. And this is going to help keep their blood sugar up for a longer period of time. So some of your complex carbohydrates are going to include your proteins, such as peanut butter, or maybe a slice of bread, especially your high grain breads, multigrains, etc. With these clients, we need to monitor their blood glucose and encourage them to eat within 15 minutes of insulin, and encourage regular meals and snacks. Okay, so we've gotten through all of the oh goodness, my mind is going now. We've gotten through all of the review, so let's talk about some of the medications. First of all, we're going to talk about our thyroid hormones. Not going to talk a whole lot about them, but it's really important for you to be familiar that with your thyroid replacement medications, that they take them in the morning about 30 to 60 minutes before food intake. Be aware that tube feedings can impair with the absorption, and it's really important for us to monitor their lab levels. And once again, education is extremely important because we need to make sure that they're very familiar with the fact that they need to be taking this medication, whether they're seeing changes or not in their condition, because it can take several weeks, up to a couple of months, before they start really seeing any improvement in their condition. Once again, with some of our hyperthyroid situations, we may have some iodines that we're giving. Moving on to insulins, we have the different types of insulin. We've got the rapid acting. So I encourage you to be familiar with the onset of action, excuse me, the peak action, and basically the duration of action. Those are very important. The rapid acting insulins are going to be most like the insulin that we produce in our bodies, so most like the endogenous insulin. We would always give it before or during a meal. The short-acting insulin, such as regular insulin, this one is kind of the superhero of insulins, I guess, because we can give it in a multitude of ways. We can give it subcutaneously, we can give it into the muscle, we can also give it into the vein as a bolus medication where we just push it in and they get it rapidly, or we can give it as an infusion. It works within 30 to 60 minutes and it's going to last 6 to 10 hours, with its peak action being 2 to 5 hours. Your rapid acting and your short acting insulins are both clear insulins. Your intermediate acting insulin, such as NPH, is going to be a cloudy appearance. With your cloudy insulins, again, always draw clear before cloudy if you have to mix them. You want to gently roll the insulin between your hands to mix it up prior to drawing it up, because you want to make sure that all of those particles are equally suspended throughout the solution. It takes 1 to 2 hours before it really starts working, and it's going to last 10 to 18 hours, with the peak action being 4 to 8. Then you have your long-acting insulins. Again, takes 1 to 2 hours. It will last 24 hours with no peak action. Some clients are going to get that basal bolus or sliding scale insulin dosing. And I plan to talk about this a little bit more Wednesday during our class discussions. Make sure when we're administering insulin that you test the blood glucose prior to administration. Encourage the clients to eat after an injection, especially with your rapid-acting and short-acting insulins. And insulin is almost always, except for those rare instances with the regular, administered subcutaneously. Then we have several different oral hypoglycemics. And your oral hypoglycemics, once again, are going to be for your type 2 diabetics. Some of the more common ones, although they're coming out with so many new ones that have different actions. But the two old standards are going to be your metformin and your glyburide or glipizide. These are going to be your biguanides and your sulfonylureas. Now the that one, they have a sulfa basis to it, so if someone has an allergy to sulfa, they can also have a reaction to like your glipizide and your glyburide. Again, we need to be aware that anytime we give the oral hypoglycemics, we need to keep an eye on their overall blood sugar levels, because they can develop hypoglycemia with it, especially if they're not eating sufficiently. I'm not going to go too deep into some of your other types of oral hypoglycemics, because those, like I said, are your two old standbys. Now we also have glucagon. And glucagon is a natural hormone that is secreted by the pancreas, but we can give it, we can administer this for severe hypoglycemia subcutaneously, especially in a client that is unconscious and they don't have IV access. When they don't have IV access, that limits how we can get this sugar in their body because they're unconscious. Very important to make sure that you roll them to their side prior to injection, because one of the adverse effects of glucagon administration is going to be vomiting, and we do not want an unconscious client to be lying supine, vomit, and then aspirate that emesis. So always roll them to the side so the vomitus can roll out their mouth. The ADH or antidiuretic hormone preparations are going to be medications that are frequently given for hypotension. We may also have some bleeding going on. We can give it in the case of diabetes insipidus, because remember, with diabetes insipidus, we're not responding well, or we're not secreting that ADH hormone. And it can also promote uterine contractions. So that would be a definite contraindication, is administering it to someone who is pregnant. So these drugs actually work by causing vasoconstriction. And if it infiltrates into the tissue, the problem is it causes such severe vasoconstriction that it can also cause tissue necrosis. So if a client is receiving this intravenously, make sure that they are having their IV site monitored very, very, very closely. Different hormones that can be given. Oxytocin is often administered to stimulate labor. We have the different growth hormones that can be given. The somatotropin will stimulate skeletal growth. I'm going to let you kind of read through that yourself. Then we have our glucocorticoids and our mineralocorticoid hormones that we give with adrenal cortical deficiency. We can give it for cerebral edema. We can also give it in issues of inflammation where we're wanting to decrease that inflammatory response or that immune response. We also give steroids when we do organ transplants to help prevent rejection of the transplanted organ. And we give it for exacerbations of different disease processes. Excuse me. We talked about the issues with discontinuing it abruptly. It can cause the Addisonian crises, so we don't want to do that. We want to always taper it off if possible. This can cause increased blood glucose levels. Steroids cause immunosuppression, so we have an increased risk of infections. We have slowed healing. It can cause heart failure. It can cause Cushing's syndrome. Skin gets really fragile. We have a lot of ecchymosis or bruising. We have osteoporosis, so the bone begins to lose density. They gain weight. They have increased intraocular pressure, mood swings or psychic impairment, and insomnia. So very important to be familiar with the drugs that you're giving and the potential complications. So hope this helped. I know I've gone over an hour, but we usually take about 3 hours in the classroom. So Again, if you have any questions over any of this subject matter, please send me an email or write it down and ask me on Wednesday. I hope you all have a couple of good days to start off your week, and I will see you Wednesday morning.